Today I'm going to discuss how to perform a subacromial bursa injection. Let's start with the indications. Subacromial bursa injections are useful for diagnostic and therapeutic purposes. The injection can help you in the clinic to determine if a patient has true rotator cuff weakness or weakness due to pain, since their physical exam might improve after the lidocaine kicks in. Any condition along the spectrum of rotator cuff diseases that causes subacromial bursitis may respond to corticosteroid injection. Injections are indicated once conservative therapy fails. Conservative therapy includes activity modification, NSAIDs, and physical therapy. Studies have shown that subacromial corticosteroid injection provides short-term pain relief that is greater than placebo and at least equal to NSAID therapy. The evidence rating of B indicates that the studies were well-designed, non-randomized studies or lower-quality randomized controlled trials. The surface anatomy of the shoulder is important for finding the injection sites. The two injection approaches we will be learning today are the lateral and posterior approaches. The anterior approach carries a higher risk of pneumothorax or puncturing of the great vessels, and therefore we will not be teaching this method. The acromion is a flat depression of the lateral edge of the spine of the scapula. The acromion has a lateral edge, and underneath this lateral border is the site for the lateral injection. The posterior injection site is located in the soft tissue depression 1 centimeter below the posterior corner of the acromion. The coracoid process is a hook-like bony prominence on the anterior portion of the scapula. The subacromial space is bordered superiorly by the coracoacromial ligament stretching between the coracoid process and the acromion. The contents of the subacromial space include the subacromial bursa and the supraspinatus tendon. To inject the subacromial bursa, you will need the standard injection supplies. This includes alcohol swabs and betadine or chlorhexidine to disinfect the skin. A 5 or 6 cc syringe with a 22 or 25 gauge 1.5 inch needle is used for the injection. An 18 gauge needle can be used to draw up the medication. You will draw up 1 milliliter of 40 milligrams per milliliter Kenalog or its equivalent, with 4 milliliters of anesthetic. We typically use 2 milliliters of 1% lidocaine with 2 milliliters of 0.25% Marcaine. The lidocaine is quick-acting. It helps with diagnostic injections when you want to re-examine the patient after the injection to see if they have normal strength after their pain is better controlled. We add the Marcaine because it lasts longer and helps decrease the pain for the patient for most of the rest of the day. Other supplies include ethyl chloride to anesthetize the skin and gauze and a Band-Aid to stop the bleeding after removing the needle. We will now discuss the lateral approach to the subacromial bursa injection. Palpate the spine of the scapula as it turns the posterior corner to become the lateral edge. Mark the skin with an unopened pen 1 centimeter below this edge. The acromion is rather thick. If the injection site is too close to the noted lateral edge, the needle will typically hit the acromion. It may also be useful to have the patient sit at the edge of the exam table to allow their arm to dangle freely and allow gravity to open up the subacromial space. Clean the skin with an alcohol pad and a chlorhexidine swab or 3 betadine swabs. You should allow the chlorhexidine or betadine to dry completely before proceeding with the procedure. This is a no-touch technique using non-sterile gloves. It is critical to identify the landmarks and site of injection prior to prepping the site. To inject the bursa, spray ethyl chloride on the skin overlying your mark until the skin turns white. Just before inserting the needle, make sure to shake the syringe so that the steroid which has precipitated out of the solution can be mixed back in. Insert the 22 or 25 gauge needle quickly through the skin at the midpoint of the lateral edge of the acromion and angle the needle slightly upwards under the acromion to full length. Inject the pre-drawn steroid anesthetic mixture as long as there is no resistance to flow. Steroid injected directly into a tendon may cause tendon rupture. Remove the needle and apply pressure with a gauze until any bleeding has stopped. Then apply a Band-Aid. We will now discuss the posterior approach to the subacromial bursa injection. Palpate the spine of the scapula and locate the posterior corner before it becomes the lateral edge of the acromion. Mark the skin with an unopened pen 1 centimeter below this corner. The acromion is rather thick. If the injection site is too close to the noted posterior corner, the needle will typically hit the acromion. It may also be useful to have the patient sit at the edge of the exam table to allow their arm to dangle freely and allow gravity to open up the subacromial space. Clean the skin with an alcohol pad and a chlorhexidine swab or 3 betadine swabs. You should allow the chlorhexidine or betadine to dry completely before proceeding with the procedure. This is a no-touch technique using non-sterile gloves. It is critical to identify the landmarks and site of injection prior to prepping the site. To inject the bursa, spray ethyl chloride on the skin overlying your mark until the skin turns white. Again, just before inserting the needle, make sure to shake the steroid in the syringe. Insert the 22 or 25 gauge needle quickly through the skin and angle the needle slightly upwards under the acromion towards the coracoid process. Insert the needle to full length. Inject the steroid mixture as long as there is no resistance to flow. Remove the needle and apply pressure with a gauze until any bleeding has stopped. Then apply a Band-Aid. Here is another example of a posterior approach to the subacromial bursa injection. When the patient has more soft tissue mass, the landmarks are not as visible and you must really palpate the bony landmarks. If you encounter resistance to flow, reposition the needle. Resistance may indicate that you're in a rotator cuff tendon. Injecting a tendon may cause rupture of that tendon. After the injection, you should have the patient perform Codman or gentle range of motion exercises to spread the injected fluid through the bursa. Instruct the patient that the shoulder may be numb for several hours after the procedure and that pain may be present for several days. The cortisone usually takes 72 hours to take effect. After 5 to 7 days, the patient can resume regular activity and you should recommend starting range of motion and rotator cuff strengthening exercises. Instruct the patient to return to your office if they develop redness, swelling, or increased pain at the injection site. The ICD-9 and CPT codes that you would need to document the procedure for the visit encounter are listed. This is a summary slide showing the supplies needed for a subacromial bursa injection. This is a summary slide describing the technique for a lateral subacromial bursa injection. And this slide summarizes the posterior technique for injecting the subacromial bursa. We hope you have enjoyed this presentation on subacromial bursa injections.